spread are actually much more common than primary tumors. However, 90% of all primary tracheal tumors are malignant. So the question may come up, well, why is this pertinent? It's because critical airway obstruction is the most feared complication requiring emergent intervention, which is why it's important that we know about the etiology and management of this. These are the percentages of primary malignant tracheal tumors that are present: squamous cell carcinoma and adenocystic carcinoma making about 60%. I will let you read the rest of them. The clinical presentation is actually dependent on the severity of airway obstruction and cardiopulmonary reserve. That's because tracheal tumors are delayed in their diagnosis. They have pretty non-specific symptoms, and occasionally those symptoms are shared with benign etiologies. So dyspnea is common, cough, hemoptysis, wheeze, stridor is what patients will present with. The dysphagia, hoarseness, and diaphragmatic elevation is seen, but it's seen less commonly. Squamous cell carcinomas often present with hemoptysis, just given the mucosal irritation and ulceration that you guys will see in a couple of slides. Adenocystic carcinoma presents with wheezing or exertional dyspnea, with hemoptysis only present in a minority of cases. They remain asymptomatic until stenosis exceeds about 50%. That's because effort tolerance is first affected because the pressure drop across any obstruction increases with increasing airflow velocity. And then these patients may only be identified when there's a precipitant such as infection, edema, or mucus impaction, which triggers that life-threatening airway occlusion that I was alluding to previously. At rest, these symptoms may only be present when the tracheal lumen actually narrows to less than 5 millimeters or so. Some of the things that we can do to try to investigate this is spirometry. There are many different imaging modalities, like stated here, and then bronchoscopic evaluation. So I think it's time for our first question. Should I read it out loud, Dr. Diaz? Or?
Yes, please do.
All right, so the question is, physiologically, what leads to variable intrathoracic obstruction during expiration? There's 4 choices. The variations are between pleural pressure and transmural airway pressure. So would it be positive pleural pressure, negative transmural pressure? Would it be negative pleural pressure, negative transmural pressure, or positive pleural pressure and positive transmural pressure, or negative pleural pressure and positive transmural pressure?
Okay, Shalini, I'm going to send a poll right now.
Okay.
So everybody, please answer the question. You have the answers there. Okay, so I'm going to share now the results. Shalini, can you see those results?
Yeah, I can.
Okay.
All right, so the correct answer is actually A, and I'm hoping that the next couple of slides will make that clear. Do I close the poll, Dr. Diaz? Oh, perfect.
I got it.
Okay, thanks. All right, so the science behind what the respiratory distress is being caused by. So in this first panel here, hopefully you guys can see this, the rate at which air flows into and out of the lungs is directly proportional to the pressure gradient between atmosphere and the alveoli, and inversely related to airway resistance, like we know. The resistance varies inversely to the 4th or 5th power of the airway radius, depending on whether that flow is primarily laminar or turbulent. The pressure within the pleural space is an essential determinant of airflow because it influences both alveolar pressure and resistance. And then alveolar pressure is the sum of pleural pressure and then the elastic recoil of the lungs itself, which is what this is depicting right here. Lastly, with definitions, airway transmural pressure actually determines airway caliber and resistance. And so it's the difference between the pressure inside the airway and then the pleural pressure itself, which is outside. So as transmural pressure increases, the airways dilate and resistance falls. And then when transmural pressure decreases or becomes negative, the airways narrow and resistance rises. So this is, changes that are inside the airway essentially during tidal breathing. So we'll go through what we're seeing. And my hope is that as you guys see this, the concept will solidify. So in this first panel here in A, the inward elastic recoil of the lungs is exactly balanced by the outward recoil of the chest wall. So at this equilibrium volume, pleural pressure is normally negative just because of the oppositely directed recoil of the lungs and the chest wall slightly increasing the volume of the pleural space. And then there's no airflow at end expiration because both alveolar pressure and airway pressure are zero. During inspiration in this panel, the diaphragm expands the chest wall, like we all know, and pleural pressure becomes more negative. So as the lung volume and elastic recoil increase. So this drop in pleural pressure increases your transmural pressure. So essentially it's -2 minus -10, giving you this transmural pressure of 8. The volume of lungs increases faster than they can fill with the air, causing this drop from 0 to -3 in the alveolar pressure itself. And then as this occurs, P alveolar continues to increase and then returns back to 0 when flow stops at the end of inspiration. And then lastly, in this panel right here, during passive expiration, elastic recoil causes the volume to fall faster than the lungs can empty, making the alveolar pressure positive. And then P pleural pressure becomes negative. And again, if you do the formula, so +2 minus -8 makes this +10. Hopefully that helps solidify some of the concepts that I wanted to talk about next. So variable intrathoracic obstruction. Why is it that during expiration is when we see the flattening of the curve on a flow volume loop? So it's because when disease affects the extrathoracic airway, which is essentially the larynx or the trachea above the sternal notch, there's a drop in the airway pressure that reduces the transmural pressure, as is depicted here, narrowing the extrathoracic airway, increasing the resistance, and reducing the flow. During expiration, the airway dilates, and then airway pressure and transmural pressure increase and expiratory flow is preserved. Sorry, I actually said it opposite. I think I skipped a slide potentially. Let's actually do that over again. Sorry. So expiration is active here. There's contraction of the expiratory muscles pushing the chest wall inward against the lungs, and pleural pressure is becoming positive. So this is augmenting your alveolar pressure here, which is also causing your transmural pressure to increasingly become negative downstream. That's reducing your airway radius and increasing your resistance. Thus, that narrowing is occurring actually at the level of the bronchioles because the structural rigidity of the trachea and the bronchi makes them resistant to the negative transmural pressure itself. Extrathoracic, so I covered this except for in the wrong slide, so we can do it again. So extrathoracic airways, just larynx or trachea above the sternal notch, the flow limitation is occurring primarily during inspiration. And that's just because of the concept that we've been talking about for the past couple of minutes, where your transmural pressure is essentially negative, increasing your resistance and then reducing your flow. The next couple of slides are just the flow volume loops. And essentially this is showing us variable intrathoracic, variable extrathoracic, and fixed airway obstruction in the panels themselves. Occasionally, disease of the intrathoracic or extrathoracic airway causes a similar degree of flow limitation during both inspiration and expiration, and that's actually referred to a fixed large airway obstruction, as we see in panel C here. So imaging, what are some of the things that we can do to diagnose this and help us out? So there's standard CTs. They actually underestimate tracheal wall involvement and invasion of adjacent mediastinal structures. So there's many different imaging techniques that have come out of late. One of them is multiplanar imaging with 3D construction. So essentially it's, precision and accuracy are improved when you can put up different modes. So axial imaging, multiplanar, reformation, and then endoluminal views. What they do is the intraluminal, extraluminal anatomical structures are put together with thresholds, and those thresholds have to be appropriate because it affects the diameter of the airways. Inappropriate thresholds can actually cause artifacts. It's also often necessary to use different threshold values when viewing the central airway and the distal airway. The other type of imaging that's used is something called multi-detector CT-generated virtual bronchoscopy. It is development of 3D visualization techniques down to the 6th to 7th generations, essentially. There's Belgian physicians that had done a study on this and found that threshold values of -400 to 600 hysteresis was optimal for visualization of the central bronchial tree, with having a different threshold for distal airway branches. Lastly, PET scan is actually used to help determine, obviously, the extent of the disease. It can also differentiate between the histology of the tumor because squamous cell cancers have more radiotracer uptake compared to adenocystic carcinoma. So bronchoscopy is, the diagnostic modality of choice in all airway obstruction. The timing is something that seems to be debatable, with some bronchoscopists initially recommending flexible evaluation of all referred cases as opposed to deferring that airway inspection to the time of rigid bronchoscopy. And I'll tell you the reason in just a second. So obviously bronchoscopy allows for a detailed evaluation of the lesion. You can do patency assessment of the airways distal to the obstruction and examination of the mucosa itself. The reason why flexible bronchoscopy may actually be dangerous in patients with severe airway obstruction is because that obstruction can be worsened by the bronchoscope physically occluding that limited airway. And then on occasion, we try to overcome this problem in the bronch suite or, when we're upstairs in MICU or SICU, wherever we're evaluating these patients by using ultra-thin or pediatric scopes. If you are in the bronch suite, you can actually exacerbate respiratory failure by the moderate sedation that we're giving, as we've seen on occasion. If there ever is a concern about being able to secure the airway, you should take them directly to the operating room so that you can have a prompt evaluation with a rigid ventilating bronchoscope, because it has the advantage of concurrently controlling ventilation and examining the airways. You can also do larger instrumentation with more options for therapeutic intervention. You could also insert the flexible bronchoscope within the rigid barrel itself to examine the lobar and segmental airways. Location of pathology is on descriptors described as upper, middle, lower third of the trachea or in either mainstem bronchi. The surgical implication there is that upper and middle trachea can be resected, and the length of the resection itself is limited to about 40 millimeters at the level of the carina. Anything greater than that is often associated with anastomotic complications like granulation, stenosis, or dehiscence. And then the degree of endoluminal occlusion is actually described in 5 different categories, being less than 25%, 26 to 50%, 51 to 75%, 76 to 90%, and 90% to complete occlusion. Of course, these are estimates that are done at the end of expiration usually, because the severity is measured at the worst point in the respiratory cycle. So our second question is, which of the following is not a complication of rigid bronchoscopy? A, esophageal perforation, B, bleeding, C, airway fire, D, laryngeal injury.
Let's see. We have 48% people who have voted. You have more? There you go. There are the results, Shalini.
Okay, so 40% of you got the correct answer, and it's airway fire. That's because airway fire requires the application of heat energy and therefore is not a direct complication of rigid bronchoscopy. The additional complications that can occur include injury to the lips, teeth, gum, injury to the tracheobronchial walls, hypoxemia, pneumothorax, and the pneumomediastinum. Before we get into the nitty-gritty of squamous cell carcinoma and adenocystic carcinoma, I wanted you guys to see a picture of what things look like. So panel A here is what squamous cell carcinoma in the lower trachea looks like. This is a typical presentation of adenoid cystic carcinoma, which is occluding the left mainstem bronchus. This here is metastatic melanoma in the upper trachea. D right here is invading esophageal cancer on the posterior membrane of the upper trachea. This is something that we get questioned a lot by at least Dr. Peralta in the bronch suite. It's exorbitant cartilaginous nodules from tracheopathica osteochondroplastica. That's always a mouthful to say. And then panel F right here is just post-stent removal granulation tissue, which is limited in nature. So our last question of the lecture is a 63-year-old male presents with progressive dyspnea on exertion for 6 months. He has had a chronic cough with yellow phlegm, but no hemoptysis. His past medical history is significant for COPD, for which he is on albuterol and tiotropium. Neck and chest computed tomography show 2 masses in the upper trachea. He has a 90-pack-year history of smoking, but no history of recreational drug or alcohol use. Examination reveals normal vital signs. No wheezing or stridor was observed, but decreased breath sounds were noted bilaterally. PFTs reveal a moderate obstructive ventilatory impairment with an FEV1 of 55%, a peak expiratory flow of 45% predicted, scooping of the expiratory limb, and flattening of the inspiratory limb. What pathology would you expect after biopsies are performed? A, small cell carcinoma, B, adenocarcinoma, C, squamous cell carcinoma, or D, adenoid cystic carcinoma? Perfect. Most of you got it right. It is C, indeed. So let's talk about some of the specifics of squamous cell carcinoma. It is the most common primary malignancy of the trachea, as we saw earlier. It is associated with habitual cigarette smoking. It affects 2 to 4 times more men than women, typically in the 6th and 7th decades. The usual diagnosis is within 4 to 6 months of symptom onset. It can be either exophytic or ulcerative, the ulcerative portion leading to the hemoptysis presentation. It is distributed over most of the trachea. 33% have either mediastinal or pulmonary metastases at diagnosis. Metachronous or synchronous lesions are common because as many as 40% of tumors can develop before, concurrently, or after carcinoma of either the oropharynx, larynx, or lung. And then if the membranous trachea wall is actually involved, you should consider invasion from primary esophageal tumor as being an entity. Expression of PD-L1 in the resected tracheal squamous cell carcinoma was about 75% in studies. It can serve as a biomarker when patients are being considered for alternative therapies, so do keep that in mind. Moving on to adenoid cystic carcinoma, it arises primarily from the bronchial glands. It's not associated with cigarette smoking. It's equally distributed between sexes, most common in patients in their 4th and 5th decades. The usual diagnosis is more than a year after symptom onset. It has a propensity to spread along both submucosal and perineural planes. Only 10% of these patients have either regional lymph node or remote metastases. There are 3 histologic subtypes of adenoid cystic carcinoma. Cribiform is the best prognosis, trabecular and solid, with solid being a worse prognostic factor. It's usual that these 3 patterns are actually mixed in one tumor. There's a grading system for adenoid cystic. So grade 1 has no solid component, grade 2 has less than 30%, and then grade 3 has more than 30%. We're going to talk a little bit about survival data, which is what this slide is. So patients with adenoid cystic carcinoma on this Kaplan-Meier curve essentially statistically do better with a better overall survival than those diagnosed with squamous cell carcinoma. The p-value on this was 0.0001. Overall survival for adenoid cystic carcinoma was 77.8%, while for squamous cell carcinoma it was 8.4%. These same individuals also did a study on ECOG performance status, and as we know, better ECOG you have, the better ideally you should do. So patients with performance status of 0 or 1 had better overall survival than those with a performance status of 2. The 5-year overall survival for patients with an ECOG of 0 and 1 was 36 and 26% respectively, while it was 0% for patients with an ECOG of 2. This was an article that I found was interesting. So it was in Lancet Oncology in 2006. They've essentially tried to propose a classification for TNM and staging for malignant tracheal carcinoma. We can ask the group at the end if this is something that is utilized at this point or not, because there didn't seem to be much data on utilization of it from all of the studies that I had read. For management, so tracheal resection is what ideally is approached, but if we're unable to pursue that, then there are adjuvant therapies that are available for unresectable tumors in the form of radiation and chemotherapy. I think some of the things that they're doing now and talking about in papers are pretty interesting, and that includes tracheal allograft and autologous tracheal substitution, which I'll talk a little bit about in the next coming slides. So tracheal resection, it essentially is a surgical technique that consists of mobilizing the entire trachea by conducting a dissection along the anterior midline plane. And then you have to be cautious about avoiding injury to the lateral blood supply of the trachea. And you'll see why that's important in just a few minutes. Also the recurrent laryngeal nerves in the esophagus. Then what the surgeon does is essentially does a complete circumferential dissection around the trachea and the tumor planes. The trachea is divided distal to the location of the tumor, and then there's traction sutures that they place along the lateral wall, which is what this is trying to show here. The surgeon will intubate the distal trachea with an armored endotracheal tube or small catheter for jet ventilation. This is the small catheter for the jet ventilation. Then the disease segment of the trachea is actually divided proximally and removed. After that, they place interrupted absorbable sutures sequentially around the trachea to complete the primary anastomosis. Occasionally, in about 6% of patients, release maneuvers are necessary to achieve this approximation. So the muscles, that connect to the hyoid bone, the mylohyoid, geniohyoid, and genioglossus are essentially separated, which is what panel A is showing. Here, they're talking about the lesser cornu of the hyoid bone with the chondroglossus muscle that's transected. You will see that in each of these panels, the digastric muscle slings are always attached to the hyoid bone and left intact. In panel C right here, it's the suprahyoid membrane and preglottic space that's opened to achieve that release maneuver. In unresectable tumors, like we talked about, radiation and chemotherapy are available options, along with airway recanalization. So that being done with rigid bronchoscopy, like we talked about earlier, and endobronchial techniques, particularly with thermal ablative therapy, stenting, and tumor debulking. Systemic therapy, the form of chemotherapy, it doesn't really have a consensus about use. Most commonly agents, so the CDDP stands for cisplatin. It's most commonly used, followed by cyclophosphamide and etoposide. The use of concurrent chemoradiation for tracheal squamous cell carcinoma originates from data within the head and neck literature, just showing decreased local and regional reoccurrence in high-risk patients when combined treatment is used. This was an interesting study that was done in a Polish institution that I'll talk to you guys about. So radiotherapy is used frequently in adenoid cystic carcinoma as an adjuvant therapy after surgery because residual microscopic disease is common. So in this group, what they looked at, it was a retrospective study in a Polish institution from 1997 to 2015. They had a regional cancer database that they searched for patients with tracheal neoplasms. Among them, 418 patients was what they came up with, 160 from their regional cancer database and 258 from their hospital database. They found only 58 cases that met their inclusion criteria. Their inclusion criteria was that these individuals would be referred to the hospital due to tracheal tumor with supporting histopathological diagnosis of tracheal cancer. So out of the 58 patients that they ended up with, 48 were treated with ionizing radiation. In 25 cases, RT was the only treatment modality used. 11 patients were irradiated with curative intent, 14 with palliative radiotherapy. Brachytherapy was also a part of treatment in 8 cases, and 3 of them it was used as an additional boost to radical external beam radiotherapy. Essentially, the aim of this slide is to show that those patients who received radiotherapy had better overall survival in spite of the large heterogeneity of the group, like I just mentioned, the various fractionation schemes that were used, and no uniform target volume definition throughout the analyzed period of time. Next, we're going to move on to some of the futuristic directions that are being implemented. So this is tracheal allotransplantation. I'm going to blow up some of these pictures so you guys have an idea of what's actually happening. So in the healthy native trachea, the blood supply is ensured by a network of small blood vessels penetrating the trachea between the cartilaginous rings. So successful grafting of a segment of trachea requires the segment to have an intact and independent blood supply. So in humans, it's difficult to achieve revascularization because the trachealis muscle essentially forms a barrier for mucosal revascularization. Heterotopic tracheal revascularization occurs in a safer way after excision of that membranous trachea. So essentially, that's what this is. They've taken out the posterior membrane of the trachea. So what they do is they take a freshly harvested tracheal allograft and wrap it with fascia and subcutaneous tissue on the radial side of the forearm. This blue right here is fibrin glue, and it's placed on the luminal side to prevent the mucosa from drying. Before implantation, they also make these partial incisions in alternating anterior intercartilaginous spaces. So revascularization is actually achieved by outgrowth of these capillary buds like you see here from the fascial flap, uniting with those on the adventitia, and the adventitia is here in blue. So full revascularization and mucosal regeneration of the cartilaginous trachea is achieved within 2 to 4 months of the trachea being implanted in the forearm. And then this was interesting. So after the revascularization and mucosal regeneration has occurred, they take buccal mucosa from the recipient itself and introduce it into the mid portion of the allograft. I tried to look into why exactly they did this. I wasn't able to find much, but from what I did find, it becomes the central part of the transplant, and the mid portion is grafted with a full thickness graft. This is done after withdrawal of immunosuppressive drugs so that immunologically induced lymphocytes can attack the microcirculation and lead to thrombosis of donor-derived blood vessels and necrosis of the mucosal layer so that, there isn't rejection of the graft itself. Cartilaginous tissue, interestingly so, seems to escape this immunologic reaction just owing to the absence of blood vessels and because chondrocytes are protected within the matrix itself. The other technique that is being used is autologous tracheal substitution, and you'll see why this may be something that is favored and is a valid option in both benign and malignant disease in a few seconds. So the neotracheal conduit, which is what this is constructed from a large rectangular fasciocutaneous flap, essentially harvested from the patient's forearm. The skin of the flap is rotated around a silicone tube. On occasion, the Dumont-Weiss stent is used, with the diameter being approximated to be slightly larger than that of the normal trachea. This tubular conduit is supplied by the radial artery and vein, is made up of skin along its inner aspect and of fascia in its outer aspect. So before transforming the fasciocutaneous, essentially it's a rectangle at first and is made circular. It's sutured in its main lengths together, and several costal cartilaginous segments are placed. This is what this is. It doesn't come across as well, but essentially it's 6 to 7 cartilaginous segments that are taken from the patient's rib cage itself and inserted between the skin and fascia. So revascularization of this flap, which is what this panel is depicting here, is provided by microanastomoses that are performed with magnification microscope between the radial vessels of the flap and the small neck vessels. The most commonly used arteries for this are the internal thoracic artery or branches of the subclavian or external carotid arteries. The reason why this technique is favored is because it doesn't require immunosuppression and allows for resection of the posterior tracheal wall, just making it a more viable option in both benign and malignant disease. We'll talk about secondary tracheal tumors next. So this was a systematic review that was done at MGH and published in the Annals of Cardiothoracic Surgery. So they looked at 160 case reports or case series identifying approximately 2,200 patients between 1978 to 2017. The mean characteristics that they found from this was that patients were 58.5 years old and 58.4% of them were female. The most common histologic types were well-differentiated thyroid cancer, unspecified esophageal cancer, and squamous cell carcinoma of the lung. In 9.5% of patients, the tumor was not otherwise specified, or there was a mix of tumor histology that couldn't be defined for the patients. Clinical presentation is very similar to what primary malignant tracheal tumors would be. The presence of symptoms, however, in this review was only recorded in 50.4% of cases. So among the patients that did have symptoms recorded, the leading symptom was dyspnea at 31.8%, neck mass that accounted for about 19.5%, voice change or hoarseness in 15%, and then hemoptysis in 13.7%. Interestingly enough, 4.8% of these patients were asymptomatic. Moving on to benign tracheal tumors, they're rare. They make up about approximately 1.9% of all lung tumors. Most commonly, there's squamous papillomas and hamartomas. So I'm going to talk to you about squamous papillomas next. Essentially, they're difficult to control once they've reached the tracheal bronchial tree. They cause significant morbidity, as you would expect, and 2% of these cases undergo malignant transformation. You should perform a biopsy to confirm the diagnosis. HPV types 6 and 11 are the implicated etiologic agents in this, and it's thought to be because there may be impaired HPV-specific T-cell responses determining the infectivity. As you see, the symptoms, again, include cough, progressive dyspnea, hoarseness of voice, wheezing, stridor, as we have seen with all of these cases. Management, so there isn't treatment that's consistently shown to eradicate recurrent respiratory papillomatosis. Removal of the papilloma tissue as completely as possible without compromising normal airway wall structures may reduce the recurrence and risk for malignant transformation. There's many different ways in which that can be approached. So bronchoscopic therapies include electrosurgery, laser resection, microdebridement, rigid bronchoscopic debulking, cryotherapy, brachytherapy, and photodynamic therapy. I'm going to talk about laser therapy. There's many different kinds of lasers, but the two lasers that seem to be compared is one called ND-YAG and the other one CO2. ND-YAG laser therapy can lead to a lower rate of recurrence compared to CO2 laser therapy at about 1 year follow-up. That may be because the vaporizing CO2 laser energy, when compared to ND-YAG, doesn't penetrate as deep. So ND-YAG laser therapy can provide deeper coagulation, allowing for destruction of that HPV-infected basal layer, which is thought to be the region that's responsible for regeneration of the papilloma tissue itself. The concern being, when you're using ND-YAG is you have a laser plume, which is why we use protective equipment when we're taking care of these patients. Suctioning has shown to potentially decrease that laser plume that may occur. Microdebrider is another method that's used. It's mostly utilized by otolaryngologists. So it prevents thermal injury. Post-procedure edema associated with the use of laser is minimized because tissue injury is essentially resulting from a shaver technique, which is confined to the superficial mucosa. Additionally, there's no risk of laser fire burns or risk of aerosolized viral DNA particles. I tried to look into microdebrider, comparing it to ND-YAG. I didn't find many studies just talking about the fact that you needed destruction of that HPV-infected basal layer, because you wouldn't be able to get to that with the microdebrider. There are adjuvant treatments that are available And the three indications for which you use adjuvant therapy is if surgery is required more frequently than 4 times a year, 4 times a year for 2 years, the papilloma is spreading outside the larynx, or rapid recurrence of the papillomas with airway compromise. Some of the therapies that are available out there include EGFR, tyrosine kinase inhibitors, retinoids, or intralesional injection of antiviral agents like cidofovir in an attempt to essentially induce growth arrest or apoptosis and inhibit the proliferation of those cells itself. Lastly, this is, I thought, a good summary slide. Essentially, gives you an algorithm of how you should approach these patients. These are all of the references. These are the people that have supported me throughout my life. I'm very thankful to them. So that is the end of my presentation. Thank you very much.
Well, thank you very much, Shalini. That was a great lecture, very informative. So everybody can actually have any questions. Anybody can ask. Oh, virtual applause, says Dr. Tatum. Good. You all guys can talk right now. So you can use your microphone. So Shalini, one of the things that you mentioned in the use of in papilloma, one of the things that sometimes is questionable, and this is still in debate. I mean, a lot of people believe that the use of laser, could be sometimes dangerous, and the reason for that is for laser you need an airflow that can deliver the laser. So it's a belief sometimes that it could disseminate the papillomas or the viruses and create more problems sometimes. So some people may not use it. Again, it's still debatable. A lot of people actually use have to be very careful with the masks that you use in order for that not to disseminate the viruses. But again, it's debatable in general. There has some where there's no studies that have shown that the main thing that we do here, at least at Henry Ford, is we use microdebrider. I think that the main thing is that you have to remember that these papillomas will come back, so there's recurrence of them, and unless you act on what's really causing the patients to develop these papillomas, then it will actually return. So sometimes, it's just the fact that the infection, the viral infection, the viral load is too high, that they tend to recur very fast. Some other people just recur very slow. It's really hard to see. There are some medications, as you already mentioned, like cidofovir, that can be used overall when there is more disseminated papillomas, and if there is already been conversion to cancer squamous cell, which we have seen also in some patients. Anybody has any questions?
Javier, I have a question.
Yes.
Shalini, thank you for your presentation. My question to you is the tracheal transplant or reconstruction using muscle flaps and cartilage. What is the success rate, and are there any limitations in terms of patient selection, and who would be appropriate or inappropriate for this procedure?
Yeah, so I tried to look into that. It talked about individuals who have comorbidities that would prevent them from doing this procedure, just as any other surgical procedure is the implication that they talked about a lot. As far as the success rate with this, I couldn't tell because they were small case series. The largest case series that I could find actually included 8 patients, and they talked about a success rate of around 30%. But again, it's a very small population that they were talking about doing this in, so I don't know I think it's something that's still being evaluated at this point.
Good. Any other questions? I think the review of physiology was pretty good in the beginning with the reasoning of the physiology behind obstruction. I think that's something very important overall for the fellows to remember. We tend to see the patients and you can explain better when you know what's going on. That was really great.
Thank you.
Any other questions? Okay. So thank you very much, Shalini. I appreciate it. That was a really great lecture. So we're going to, I'm gonna mute here, and can you stop screening?
Sure.
Perfect. Okay, so while we wait for the next speaker and to connect and have everything ready, I'm just gonna take 5 minutes right now. I said there was gonna be a surprise. And hold on, let me. And what is this? Okay, so everybody can see this now. So this is an award, and this is for our fellows. This is a way to say thank you for everything that you have done. All of you have already received a small gift given by the fellowship. It's just a way to say thank you to all of you. But this is a little bit more. We're very proud to present this. And the way it's gonna happen, oops, sorry, what is this?
And like I said, the hypoxia-mediated vasoconstriction, pH related to that. So all those things are going to lead to increased PVR as well. All right, so when we talk about pre and post capillary pulmonary hypertension and the long-term effects on hemodynamics, I just thought this was a nice slide as well, kind of putting the pre-capillary factors on one side and the post-capillary factors on the other. So normally our pulmonary vascular bed is going to have pretty low resistance and good compliance. And the RV afterload in normal state should be less than the LV afterload. But when you have chronic pulmonary hypertension and a sustained, elevation in your PA pressure, you're going to have chronically increased RV afterload and a less compliant RV. And we kind of talked about the cellular level changes where you get less angiogenesis, you get vascular remodeling, endothelial dysfunction, all that. So you can see over here, the pre-capillary, the things we chronically think of, right? So our pH connected with, associated with connective tissue disease, HIV, CTEPH. On the post-capillary side, obviously, I think we're all very familiar with seeing left heart disease and the changes there. So all those things are going to put more stress on both the RV and the pulmonary artery wall, lead to the long-term effects we just mentioned of increased RV wall stress, initially adaptive and then maladaptive remodeling, and ultimately poor contractility and right-sided diastolic dysfunction. Then you'll see with that, that the left heart will be impacted with chronic RV dysfunction. If there's, shift of the interventricular septum in the balance, then obviously you have reduced left-sided preload, left cardiac output, and worsened blood flow going forward. So mortality rates of patients with pre-existing pulmonary hypertension undergoing cardiac surgery are upwards of 25%. In these studies, some of the risk factors we can look at when we're evaluating patients with PH to undergo surgery are, what is their mean PA pressure? Is it greater than 50? What is their PVR? We often have these, measurements in our patients that we see in clinic, obviously, because many of them have had right heart caths. You can look at the systolic PA pressure, your transpulmonary gradient, a PVR to SVR. This actually is portends a decreased risk of less than 0.33. So if you think about the things that you can optimize, how can you get their PA pressure lower, their PVR better, in terms of getting them ready for surgery? Obviously, those things will be optimal in decreasing their risk. So this is kind of a busy slide, but I thought it was important to talk about some of the different studies looking at morbidity and mortality in PH patients. And this one is specifically in non-cardiac surgery. So you can see over here in a study in 2005 by Ramakrishna, they had 145 surgical patients, and PH was from all different etiologies, and their perioperative mortality rate was 7%. Right here next to it, you can see this is a smaller case series, only 21 patients with moderate to severe PH, but they showed an 18% mortality rate. A lot of these studies, right, are retrospective in design, and these two are really just shortly after we had good PH meds. And then if you look at, morbidity, not just mortality, you can see the numbers here as well. And of course, this is going to be influenced by, how severe is their PH, what New York Heart Association class are they, higher NYHA class 2 to 4, or 3 to 4, I should say, are at higher risk. So whatever you can do to bring them down a functional class, obviously is going to decrease their morbidity and mortality. Okay, so several factors have been identified as predictors of increased risk of perioperative complications, both patient factors and surgical factors. So again, higher New York Heart Association functional class is going to mean you're at higher risk for morbidity and mortality. If you have any history of heart disease, PE, renal insufficiency, I feel like these are patient factors that almost all of our patients have. And then can't always control this, but surgical factors, right? So what is their ASA? Is this emergency surgery, or is this something you have time to optimize them for? How long are they going to have to be under anesthesia? We'll talk a little bit more about that. And then whether or not they need vasopressors. In a lot of retrospective studies, the main contributors to morbidity and mortality were heart failure, arrhythmias, prolonged intubation, prolonged ICU and hospital length of stay. So when we think about patients with PH going for non-cardiac surgery, I just thought this was a nice chart too. So here are our risk factors, and then over here you can look at the different tests that can help you get a sense of what their perioperative risk is. So do they have right axis deviation or evidence of RVH on an EKG? What does their echo look like? What does their right heart cath look like? Are they grouped? Are they pre-capillary, post-capillary, or are they just pre-capillary? And then again, the surgical factors, which are often not necessarily within our control. So when we're evaluating patients with PH preoperatively, obviously we want to kind of do a hemodynamic assessment. We'll often have a recent echo or cath. Decide, is the benefit of this surgery for their quality of life and prognosis wise, does it outweigh their risk? If they're on anticoagulation, what's their risk of being off anticoagulation? How high a risk are they to bleed? What other comorbidities do they have that can be optimized? So when we have time, we obviously want to optimize them with oral or IV therapies prior to undergoing surgery. And then kind of with anesthesia and pharmacy, think of, is there a way we can minimize the risk of anesthesia for these patients? Could they get a regional block or a local block? Is that going to be enough, or do they have to have general anesthesia? And you can see kind of, and we talked about multidisciplinary approach in looking at these patients, trying to evaluate their other comorbidities and optimize them. So if they have COPD, can they be, you know, is their inhaler package optimized? If they have arrhythmias, is that optimized, et cetera, et cetera. We know that New York Heart Association functional class at diagnosis of PH is predictive of someone's survival. So I think we're all pretty familiar with the functional classes, with 1 being really you're not limited at all, and 4 being you're symptomatic at rest and really can't do a whole lot. A lot of our patients falling in the kind of 2 to 4 range. But if we can optimize them and bring down their functional class, that's associated with a much better prognosis. So some of the things that we want to focus on perioperatively, again, are to avoid any systemic hypotension, because that can make RV ischemia worse on an already strained RV. You know, any myocardial depression, you want to kind of avoid that as well. Can reduce your RV contractility. Avoid acute elevations in PA pressure due to the risk of RV failure from the increased afterload. Make sure patients have adequate pain control so they don't have a sympathetic surge and rise in their PVR. And then avoid things that lead to hypoxia, hypercapnia, because all of those things, acidosis, can lead to increased pulmonary vascular resistance. So hemodynamic monitoring that can be done around the time of surgery. Obviously, we have our standard things that patients get: ECOG, pulse ox, temperature, all their vitals. An art line for measuring systemic blood pressure. You can consider pulmonary artery catheters or transesophageal echo. You know, you have to look at the risk and the benefit, but if that's going to guide your therapies around the time of surgery, or help with determining vasopressors, fluid administration, et cetera, I think it's something to definitely consider and think about using as a tool. TEE can help kind of determine how well the RV is contracting, is it dilated, an estimate of the PA pressure, but then can also cause bad hemodynamic effects. You really have to decide, is that worth it or not, and do you need that kind of monitoring? So just kind of some general considerations for specific anesthetics and sedatives. Etomidate really does not have much impact on myocardial contractility and systemic vascular resistance, so sometimes it's a good one to think about using. Propofol, and see that we use sodium thiopental really anymore, but you want to avoid those because, of course, they can cause hypotension and reduce contractility, leading to more stress on the right side of the heart. Ketamine is one that can actually decrease your PVR, but it can increase your systemic vascular resistance. So you have to carefully look at their hemodynamics and decide, is that something that would be useful for that particular patient. In general, most anesthetics and sedatives are going to decrease your systemic vascular resistance and cause hypotension, especially in our patients who often have fixed cardiac output. So we really have to be very careful with them, and if they have to be used, we try to minimize the amount of time and all that. And then nitrous oxide, can increase your PVR and worsen RV ischemia as well. I just thought this was a nice chart of the different inhalational anesthetics that we use and how they contribute to causing stress on the RV. So you can see here the fluorines really reduce RV contractility, and here really increase your pulmonary vascular resistance. So if you can avoid it, ideally you should. So this is just another table. I don't want to spend a ton of time on these tables, but I did think they were useful just to kind of look at in terms of, okay, what pharmacologic class do they fall in, and what are some of the frequent adverse cardiac effects that we see. So you can see almost all of these cause some degree of hypotension. I would say less so with etomidate, but because of adrenal suppression, you can see a little bit. But Precedex, propofol, all these things obviously can cause hypotension and bradycardia, and in folks with fixed cardiac output, that can be really dangerous. This one might be a little blurry for you guys, sorry, but it's just looking at neuromuscular blockers and their cardiac effects. You can see up here succinylcholine, and then Rockfec and cisatracurium. But again, a lot of them can have bad cardiac side effects. So You know, with sex, you can even see hypotension. The bradycardia is more often in children. Same thing with vecuronium. So if we don't have to use these, obviously it's ideal. In some cases you need to, and it is what it is, but important to think about, you know, if you can get away with not using them, how to optimize RV function. So my next question is, how does positive pressure ventilation increase right ventricular afterload? So A is increase in RV preload, B, compression of the pulmonary capillaries and increased pulmonary vascular resistance, C is increased LV afterload, and D is reduced LV compliance.
Okay, guys, we have 13 votes. Please go ahead and vote. Okay, Jen.
Okay, awesome. Basically, the majority of you got it right. Here we are, B again. B is the correct answer, and we're going to go over why. Okay, so with positive pressure ventilation, you actually increase your pleural pressure, which is going to decrease the amount of preload you have, increase your RV afterload. And we'll talk a little more about PEEP and positive pressure, but essentially you're going to have compression of the capillaries, and this is going to increase your PVR, which ultimately is going to lead to decreases in RV and LV preload, and then reduce your LV compliance because of interventricular dependence. So I know this is a busy slide, but this was an article that Dr. Kelly gave me that was really useful for kind of understanding how spontaneous inspiration versus positive pressure ventilation affect the right ventricle. And of course, it's important to understand baseline spontaneous inspiration to compare that to positive pressure ventilation. So normally, obviously, when we take a deep breath, our intercostal muscles contract. We get more negative pleural pressure, which then increases your venous return to the right side of the heart, reduces your RV afterload, and you do get an increase in LV afterload as well. But essentially, helps you to increase your venous return and have less RV afterload. So with positive pressure ventilation, the issue is that you essentially have more positive pleural pressure, and you compress those small capillaries, and then you get decreased venous return and increased pulmonary vascular compression and resistance. Because of the baroreceptor reflex, you also get, from the initial increase in aortic pressure, you get a decrease in LV afterload. So really, positive pressure ventilation and PEEP in these folks can be really deleterious, and we want to avoid it if we can. In addition, positive pleural pressure does compress your RV and LV cavities to a degree. We kind of talked about some of this, but as you breathe spontaneously and you have negative intrapleural pressure, you have this more negative balance relative to your systemic pressures, and ultimately increased afterload. And then again, during positive pressure ventilation, your pleural pressure is going to become more positive. You're going to have less venous return and preload, which often in a preload dependent RV is problematic. And then because of the baroreceptor reflex, you're going to see vasodilation, and your systemic vascular resistance will decrease. During positive pressure ventilation in normotensive patients, the aortic pressure is usually going to be higher than the pleural pressure and RV pressure to help kind of maintain your myocardial perfusion. But in patients that are in shock, RV perfusion can be compromised with these elevated pleural pressures from things like, having high PEEP or mechanical ventilation. So something to think about. And then additionally, when we think about RV perfusion, typically occurs during both systole and diastole in patients with, normal pulmonary vascular resistance. But in chronic PH patients, their RV systolic pressure often is going to approach aortic pressure, and your systolic coronary blood flow to the RV is compromised. So the effect of PEEP on our pulmonary vascular resistance, it seems like there's this magical kind of spot at FRC. So at lower lung volumes, you can have atelectasis and actually increase PVR because of collapse of the unit and hypoxic vasoconstriction. But then at the same time, if you overdistend the alveolar capillary unit and have really high PEEPs and alveolar pressure, then you can compress those small vessels. So you really need this optimal tethering at FRC, where you open the alveoli with an appropriate amount of PEEP, and don't have much atelectasis, and this will ultimately improve your pulmonary vascular resistance. So, perioperatively, we definitely need to think about this in our patients, and then it's also important to look for auto PEEP in our lung disease patients, because this can make hemodynamic instability, worse and lead to more VQ mismatching. It's kind of this fine balance. The net effect of your PEEP and your cardiac output kind of depends on your baseline RV and LV function, what the preload is, the afterload, and then again, ventricular interdependence. So again, in our patients with RV failure who are preload dependent, PEEP often actually will decrease their cardiac output from the RV, and if they're dependent on kind of this fixed cardiac output, that can cause serious hemodynamic instability. So that's kind of RV failure. In afterload dependent states like LV failure, PEEP can actually improve your cardiac output by decreasing your systemic vascular resistance and reducing your myocardial oxygen demand. So recommendations for intra-op and post-op management in patients with pre-existing PH are to, not allow large fluctuations in blood pressure or PA pressure, because that can certainly lead to hemodynamic instability. Our usual things like maintain a MAP, greater than or equal to 65, systolic or greater than or equal to 90. Try to get that PVR to SVR ratio down if possible, and get your right atrial pressure, as low as you can, with a cardiac index greater than or equal to 2.2. Notably, norepi and vasopressin are two pressors that improve coronary perfusion and reduce your PVR to SVR ratio and help with RV performance and cardiac output. Okay, so that brings me to question 3. Which of the following factors worsen pulmonary vascular resistance? So A, hypercapnia, B, acidosis, C, hypoxia, and D, all of the above. Are we polling, Dr. Diaz?
Yeah, just give me 1 second. It's not working here. Just. Okay, now it's working. Okay, go ahead. You guys can vote. Okay, Jen.
Okay, perfect. Awesome. So basically everyone got this one. D is the correct answer. Let's see if I can advance my slide here. Okay, so when we think about things that are going to worsen pulmonary vascular resistance, we obviously want to think about things that will increase SVR as well. So things like hypoxia, hypercapnia, acidosis. We talked about positive pressure. Those are all things that we kind of want to avoid so that we can maintain cardiac output and good blood flow to the coronary circulation. If we have an acute crisis with these patients, oftentimes we're going to be trialing IV or inhaled pulmonary vasodilators. I just thought this was a nice table of kind of the principles of dealing with an acute pulmonary hypertensive crisis, or things that I think we would think about but seem obvious but may not always be, like maintaining sinus rhythm, trying to make sure you have an adequate amount of preload for these patients, trying to make sure you reduce their PVR to the degree that you can, or specifically, avoid factors that worsen the PVR. So we talked about this at the beginning, but we'll talk a little more again, just kind of this cycle of RV decompensation. So early on, you have the increases in preload and afterload, and then that leads to decreased contractility, tachycardia, increased stroke work, and RV wall tension, which, leads to more oxygen demand. Again, it's this kind of mismatch between oxygen supply and demand. And then as your cardiac output falls, you get more hypotension and RV ischemia, which then kind of gives this vicious cycle, and you don't get adequate delivery of oxygen to the myocardium. You get greater RV dilation and wall tension and decreased delivery. Ultimately, all of these things contributing to a decrease in your cardiac output. And then just things to mention that contribute to systemic hypoxemia, and things I think a lot of us think about are right to left shunt. So when we're getting an echo and looking for a bubble, how much oxygen is being extracted in terms of supply demand, and then how much gas exchange is happening. So thinking about acute versus chronic RV failure, two very different things, right? So acute, we think of more things like an MI leading to RV ischemia, or an acute PE, versus our chronic PH patients with their RV failure from long-term increase in PVR and wall stress. So we know I think this is classic, and a lot of you have seen this, but the position of the intraventricular septum during the cardiac cycle depends on the difference between RV and LV EDP. And in normal states, LV EDP is going to be greater than RV EDP. But oftentimes we see this reversed in chronic PH patients with increased pressures on the right side of their heart. So this increase in RV afterload is going to cause the septum to bow into the LV and cause this D-shaped pattern that we can see on parasternal short echo. So, and then you don't have filling of the LV. So with patients that are in acute RV failure, again, we want to think about, is there an acute cause? So is there a PE? Did they have an MI? If so, you treat those, the underlying etiologies. Or is this more of a long-term issue? If it is acute, then you want to think about things to be able to maintain their preload. So do they need, a volume challenge? What is their afterload like? What is their blood pressure doing? Are they having any of these factors that can worsen PVR in terms of hypoxemia, hypercapnia, acidosis, VQ mismatch? And then try to target whatever the underlying insult is. And I think oftentimes one of the hard things in these patients is to determine, okay, do they need preload back? Are they overloaded? Kind of what's going on with their RV. I thought this was just kind of a nice slide looking at acute RV failure management again, and kind of the principles. What I like over here is kind of, okay, what is the etiology? Is it from hypotension? Is it a preload issue? Is it increased PVR issue? Is it a contractility issue? All of these things kind of allow you to decide, okay, how am I going to manage this patient? So if it's, reduced systemic vascular resistance from sepsis, you're going to treat the underlying sepsis, vasopressors, etc. Are they dry? Is that the issue? Do they need a volume infusion? Are they having an acute increase in PVR? And do we need to use pulmonary vasodilators? Are they having a RV infarction, et cetera? So kind of the general principles are to maintain adequate systemic perfusion pressure, keep our CVP kind of within normal to a little bit higher if they need the preload, pressors if we need to maintain their systolic blood pressure and maintain contractility. Obviously treat any underlying or contributing factor like dysrhythmia as infection. If they're having, again, acidosis, hypercapnia, abnormal temperatures, all of these things you want to treat. And basically avoid big swings in airway pressure as well. And then, of course, lastly, if they need ECMO or balloon pumps or other forms of support, then those can be used as well. And just kind of like this chart as far as putting the hemodynamic characteristics of each scenario in there. I thought it was a nice summary. So around the time of surgery, spinal anesthesia can actually, especially with bolus technique, cause some hypotension and RV ischemia. So if really more when it's in the high thoracic region, but if we can avoid that, we should try. High thoracic anesthesia from the 1st to the 5th thoracic levels blocks your cardiac efferent sympathetic fibers, and then you get kind of chronotropic and inotropic incompetence. So now we're going to go on to 3 different cases here at the end, and hopefully you guys can chime in. I know they're long. I'll try and read them quickly. So we have a 54-year-old, 70 kg female with a history of severe pulmonary hypertension who comes in for an elective lap chole. We have a heart cath report in the chart from 4 months ago showing a right atrial pressure of 12, RV pressure, systolic, diastolic 42 and 15, transthoracic echo showing a severely dilated RV and moderately dilated RA. But she seems to be doing okay, no evidence that she's really fluid overloaded with JVD, hepatomegaly, or anasarca. So before induction, she gets an ART line placed. Her baseline blood pressure is 126/72. She's pre-oxygenated and then given fentanyl, lidocaine, propofol, and rocuronium. So all, I think, drugs we talked about and kind of mentioned as far as their hemodynamic effects. Gets an airway in place, and the surgical procedure starts, with pneumoperitoneum as you would expect with a lap chole. She all of a sudden gets tachycardic. Her blood pressure decreases dramatically to 78/32. And anesthesia says, okay, release the abdominal insufflation. They give ephedrine and phenylephrine, and all of a sudden her MAP improves. So some of the things I wanted to discuss in this case are what happened, what things were involved in her hemodynamic decompensation with her tachycardia and hypotension, what pre-op factors were predictive of her surgical risk, and then how did management lead to improvement in her hemodynamics. And this is where I wanted to have people chime in and unmute themselves.
So guys, everybody is able to use their microphones, so go ahead.
So any thoughts, just throw them out there. I can go back to the case if you guys want. Talk louder.
Increase in preload after removal of the intra-abdominal air.
Yep. So certainly a factor, right? So we have increased intra-abdominal pressure. That's definitely going to decrease our venous return and make RV ischemia worse. So that's definitely a factor there. Usually it's CO2 insufflation, so that can make things worse as well as far as causing more of a hypercapnic state. What other things can you guys think of? What things preoperatively, predicted her to be at worse state in terms of undergoing a procedure and a surgery? So we have this right heart cath report from prior showing a right atrial pressure that's pretty elevated at 12 and elevated RV pressures as well. and then an echo showing a severely dilated RV. So I think all of those things tell you that this patient is already pretty high risk. And then with surgery, oftentimes, right, we'll see this kind of sympathetic overdrive right after incision, which can worsen your SVR and then worsen RV ischemia as well. So this was a case basically of acute pulmonary hypertensive crisis. And then when the insufflation was released and the CO2 was removed, then we had better venous return, improvement in PVR, and forward flow. So just kind of things that I think real life case that happened, and things to think about in terms of optimizing them around the time of surgery. And then again, what things during surgery can cause issues. All of these things in patients with normal cardiac function probably wouldn't cause any big issues, but these patients obviously are very altered to begin with. Okay, so case 2, we have a 62-year-old guy, known PAH. He's supposed to undergo a revision right total knee, history of tobacco abuse, hypertension, and coronary disease. Had a stent placed 6 years ago. Doesn't really know much about the severity of his PH, and you can't find any other records in the chart or in Care Everywhere and anything. So he said that he will feel short of breath when walking sometimes, just from the parking lot into the store, but he really kind of minimizes that and talks more about his knee pain. He, since receiving his stent, has stopped taking aspirin, but did take his metoprolol. Medical history really is otherwise insignificant. So the anesthesia team sees the patient, acknowledges the shortness of breath, but just thinks that it's more related to deconditioning. And they decide to proceed with surgery. So the patient undergoes induction and intubation uneventfully. Lower extremity tourniquet is inflated, and then surgery kind of goes as planned. The procedure takes longer than expected. You have a 1 liter blood loss, necessitating transfusion, and the tourniquet's in place for about 2 hours. Once the procedure is finished, the tourniquet is finally deflated, and the patient becomes tachycardic, end tidal increases, anesthesia provider starts 50% nitrous, and cycles the blood pressure. So it's declined from 118/72 to 78/48. Decides to give a small bolus of phenylephrine and check the pressure again. So the tachycardia persists. The patient remains hypotensive, and on EKG, a mild ST depression is noted and lead to patient gets a unit of vasopressin and is put on 100% oxygen. So what was missed in this case? What hemodynamic monitoring could have been used intraoperatively? What happened when the tourniquet was released? And what medication should have been avoided in this patient? Again, please chime in.
Jen, you can go back. Can you go back to the previous slide so they can see the case? Thanks.
Yep. This one's long enough that there's 2 slides, but I think this will stay. I think the second one is probably more pertinent for you guys to see.
Guys, you can comment also on the chat box.
I can't see if people are commenting in the chat box, Dr. Diaz.
No, they have not yet.
Okay. All right, so we can go over the answers if no one wants to chime in or step up, that's okay. So essentially, I think one big thing that was definitely a red flag that was just kind of minimized was the patient's shortness of breath. They were just thinking, okay, this is probably just deconditioning his coronary disease. Well, realistically, it was related to the pH. At the very least, I think this patient should have had an art line, but again, we can consider in these patients pulmonary artery catheters or TE for better and closer hemodynamic monitoring. This was something I wasn't really thinking about or aware of when I looked at this case. When the tourniquet was released, you actually have decreased venous return and increased capacitance in the legs. So you have this buildup of CO2 and acidosis from limb ischemia, and then all of a sudden it's released into your systemic circulation and causes an increased PVR and decreased perfusion to the RV. So definitely something that I hadn't thought about before, but certainly can contribute here. And then nitrous oxide really should have been avoided because it's proven to increase your PVR. So it was used in this case and kind of made the patient's RV failure worse. Okay, last case. We have a 66-year-old female. This is actually one of the PH patients with a history of hypertension, papillary serous adenocarcinoma, status post surgery, and neoadjuvant chemo, NASH cirrhosis, got a liver transplant. So at the time of the liver transplant, she was found intraoperatively to have high PA pressures, and it was thought to be due to portal pulmonary hypertension. She was diuresed and started on oral and IV vasodilators in the hospital, with eventual transition to Remodulin, just easier administration than the Flolan. So this patient, interestingly enough, was unknown at the time of surgery, but when this all happened intraoperatively, she was found to have a mean PA pressure greater than 40, and we'll look at her echo here in just a minute. So you get this consult around the time of surgery for PH and these elevations in PA pressures, and you have to comment on kind of ventilator management, what factors, could worsen pH perioperatively, what to avoid, what kind of intraop pulmonary vasodilators you could trial, how do you give that, and then what sedatives and analgesics could you use that will reduce PVR but have minimal impact on preload and improve SVR. So think about this as you got the consult, and what kind of things are you going to recommend for this patient aside from trialing the oral and IV vasodilators in a patient that's got hemodynamics consistent with RV failure, right-sided with low wedges. Let me show you guys the echo, and then we can kind of, so some echo images. Just kind of want to show that the RV really isn't moving well. Here we have our peristernal long. We can see the same thing on here. Let me see if I can advance to the next slide here. Here we go. Okay, and then we can see a peristernal short as well, and kind of see bowing into the LV and kind of a more D-shaped septum. All right. So I think the echo speaks for itself. I could tell you all the numbers, but essentially, just in the interest of time, I'll go through this one. This patient had the echo done and then a right heart cath and a PA catheter placed. Things that we talked about during the presentation to kind of think about perioperatively and in patients like this are to avoid positive pressure if you can. So really, if you can have a PEEP of 0, if they have to be on mechanical ventilation, that's ideal from the perspective of preload and PVR. Obviously, avoid things that are going to worsen your PVR. So pain, that's going to increase your systemic vascular resistance and cause issues. Hypoxia, hypercapnia, acidosis, all of those can worsen your PVR as well. And then trialing inhaled nitric is an option. It has minimal systemic effects and can reduce your PVR. Ultimately, this patient needed Flolan and did well with that. One other thing to think of, which we may have touched on earlier in the presentation, is that ketamine, rather than using typical medications that we think of like fentanyl and Versed, which both reduce preload and cause hypotension, ketamine really has minimal effect on preload and actually reduces PVR. So something to think about from the sedative perspective. And I think that is it. Hopefully I can answer questions or if anybody has comments.
Well, that was a great presentation. I see the Dr. Oddish wrote their applause. That's pretty good. Is there any question from the audience? Sorry, Jen, what did you say?
Oh, I was just going to say, and thanks to the PH group who helped me put this together.
Yeah. So is there any comments, any questions from the audience?
I think, Jen, this was a really really well done description of what's a very complicated topic. And you've highlighted how much it really needs to be a global assessment in each situation, and the involvement of multidisciplinary collaborative team. And oftentimes, you know, we don't even agree necessarily between the surgeons and the anesthesiologists in our group. And there's a lot of risk assessment that goes into stratifying these patients for surgery. So thank you for reviewing it so clearly.
Absolutely.
Thank you very much, Dr. Otis.
Oh, hush. The folks in the room clapping at me.
Well, okay, so there's no more questions. So hold on, I'm receiving a lot of. Okay, so thank you very much, Jen. That was really good. Thanks everybody for attending. There is one more thing. As I said earlier, we're going to go with the second. Certificate, the gift certificate or gift card that will be given to our second fellow as a hero. So just give me 1 second. And